Good day, everyone. We're here to discuss the topic failure to thrive or malnutrition. Failure to thrive in childhood is a state of undernutrition due to inadequate caloric intake, inadequate caloric absorption, or excessive caloric expenditure. So, failure to thrive in childhood refers to a condition in which a child is not growing or gaining weight at the expected rate for their age. This can be caused by not eating enough food, not absorbing enough nutrients from food, or burning too many calories through physical activity. For example, a child can be failure to thrive may be significantly below the average weight and height for their age group. In the United States, it is seen in 5 to 10% of children in primary care settings, although failure to thrive is often defined as a weight for age that falls below the 5th percentile on multiple occasions or weight deceleration that crosses two major percentile lines on a growth chart. Use of any single indicator has a low positive predictive value. This condition can be a result of various factors, including malnutrition, medical issues, psychological issues, or a combination of these factors. An example of failure to thrive could be a 2-year-old child whose weight and height have consistently been below the 5th percentile on growth chart, despite receiving adequate nutrition and medical care. In this case, the child's slow growth may be attributed to underlying health issues such as gastrointestinal problem or a metabolic disorder, which need to be identified and addressed by healthcare professionals to ensure the child's proper growth and development. Cases of failure to thrive involve inadequate caloric intake caused by behavioral or psychosocial issues. The most important part of outpatient evaluation is obtaining an accurate account of child's eating habit and caloric intake. Routine laboratory testing rarely identifies a cause and is not generally recommended. Reasons to hospitalize a child for further evaluation include failure of outpatient management, suspicion of abuse or neglect, or severe psychosocial impairment of the caregiver. In many cases, failure to thrive is associated with inadequate caloric intake due to behavioral or psychosocial issues. These issues might involve the child's refusal to eat, disruption in caregiver-child relationship, or broader psychosocial stressors affecting the family environment. It is crucial to understand the child's eating habits and caloric intake accurately during the evaluation process, as this information can provide valuable insight into the underlying causes of failure to thrive. Genetics play a significant role in maintaining an individual nutritional status. Genetic predisposition combined with lack of physical activity and a high energy diet can lead to obesity and metabolic syndrome, those putting individuals at high risk of developing cardiometabolic disease. Since genetics play a significant role in maintaining an individual's nutritional status, and when combined with other factors like a high energy diet and lack of physical activity, they can increase the risk of developing obesity, metabolic syndrome, and cardiometabolic disease. This relationship emphasizes the importance of considering genetic factors when discussing the causes and risk factors of the failure to thrive and other health issues. Malnourished individuals are more susceptible to infections and related complications. Interestingly, both acute and chronic infections adversely affect the nutritional status of individuals and can precipitate nutrition. This relationship between infections and failure to thrive can observe in both acute and chronic infections. Acute infections such as diarrhea or respiratory illnesses can lead to temporary disruptions in nutrient absorption and utilization, causing a temporary decline in growth and development. On the other hand, chronic infections like tuberculosis or HIV can have more prolonged and severe effects on an individual's nutritional status, potentially leading to long-term growth impairments. So infections are essential cause and risk factor for failure to thrive. Medication. So, adverse effects of various drugs such as nausea, gastric irritation, or loss of appetite can continue to decrease food or nutrient intake. Commonly taken over the counter, like drugs such as NSAIDs, can lead to gastrointestinal and irritation. So similarly, iron tablets can also cause gastrointestinal irritation and constipation as side effects. So some medication can lead to specific deficiencies such as the drug isoniazid, which can lead to vitamins.
Good day everyone, I am Rosalie Lakman. I'm going to present to you the assessment findings or the signs and symptoms of malnutrition and the diagnostic test. So what are the common signs and symptoms of failure to thrive or malnutrition in children? So there is a weight loss or underweight, fatigue, irritability, loss of appetite, dizziness, lethargy, weakness, stunted growth, dry skin, and hair. So there are components of a comprehensive nutritional assessment that need to be performed while evaluating the nutritional status of individuals. First is the clinical history. Patient's clinical history is a crucial component of a nutritional assessment. Clinical history aims to look for indications of malnutrition and identify underlying factors that may lead to malnutrition or increase the risk of malnutrition. In assessing a clinical history of a patient, we need to take a detailed history of chief complaints. Other than that, we should ask about any symptoms such as fever, fatigue, malaise, loss of appetite, or sleep disturbances. The presence of these symptoms can be indication of underlying pathologies. For example, fever suggests active infection or inflammation. So you need to also ask about the patient's usual weight and ask if there have been any weight changes. Weight loss of less than 10% of body weight can signify underlying pathology. Weight gain can be suggestive of various underlying endocrine pathologies. Weight gain can also lead to insulin resistance, contributing to metabolic syndrome. So ask if there are any symptoms suggestive of malnutrition other than weight changes, such as rashes, sores in the mouth, dryness of skin and eyes, loss of night vision, hair loss, bleeding gums, poor healing of wounds, swelling of extremities, tingling, or numbness. Next, ask about any current major clinical or surgical illnesses, including mental illnesses. Also, ask if they are taking any medications, either prescribed or over the counter. Ask if there is any history of chronic illnesses, hospitalization, trauma, or malignancies. Next, determine also if there are any factors affecting food intake, like poor dentition, ulceration in the oral cavity, difficulty in swallowing, loss of appetite, heartburn, nausea, and or vomiting. Further inquire about bowel habits, which help assess the general functioning of the gastrointestinal system. Also ask if there is any abdominal pain, abdominal distension, diarrhea, flatulence, or constipation, which can indicate underlying gastrointestinal pathologies that affect nutritional status. So next is the dietary assessment. Dietary assessment is necessary to ensure adequate nutrition and hydration intake. It is advised to consult a qualified registered dietitian nutritionist or RDN if available to obtain a thorough dietary assessment. So the information can be collected from various sources such as the patients themselves, family members, caregivers, or medical records. History about dietary habits, frequency of meals, and serving sizes needs to be collected. Details about food preferences, restrictive diets, and allergies should be noted. Current nutrient and fluid intake should be recorded. Methods such as the 24-hour recall method, food frequency questionnaire, diet charts, observation, and etc. can be used. So next, if patients are on any nutritional supplements, care must be taken to record the frequency and dosage to limit the risk of nutrient insufficiency and toxicity. Next, if patients are on parenteral or enteral diets, information on feeding regimens, quantity and frequency should be noted. Factors affecting this feeding, such as the displacement of feeding tubes, site irritation, or infections, should be considered. The next component of the nutritional assessment is physical examination. The physical examination aims to identify signs of malnutrition and factors affecting nutritional status. So the general condition and appearance of the patient should be observed, Look for any signs of emaciation. Note whether the patient is conscious, alert, and ambulatory. Make a note of whether a patient is being examined in a hospital or outpatient setting. An initial observation of the patient's cognitive, mental, and emotional status should be noted. Also note any parenteral or enteral feeding devices being used. A patient's general condition can help determine whether a patient can meet their nutritional needs and or whether their condition is causing their malnutrition or putting them at a risk or a higher risk of nutrition deficiencies. Next is the vital signs. The body temperature, pulse, blood pressure, and respiratory rate should be checked. Temperature greater than 38 degrees Celsius can signify active inflammation or infection. Hypothermia or less than 35 degrees Celsius can be associated with conditions causing impaired nutritional status such as sepsis, trauma, burns, stroke, alcohol intoxication, and metabolic disorders like hypothyroidism, adrenal insufficiency, and wernic encephalopathy. High pulse rates apart from cardiac conditions can indicate hyperdynamic circulation. Some causes of hyperdynamic circulation that are associated with altered nutritional status are fever, anemia, pregnancy, hyperthyroidism, septic shock, beriberi, and anxiety. High blood pressure or hypertension is one of the risk criteria for metabolic syndrome. Abnormal rate and patterns of respiration can be indicative of various pathologies. For example, Kussmaul's breathing is associated with diabetic ketoacidosis or DK. Next is the eyes. Look for pallor, which may be indicative of various nutrient deficiencies such as iron, vitamin B12, folic acid, vitamin B6, vitamin C, or protein deficiency, as well as various chronic illnesses. Look for icterus, suggesting metabolic disturbances associated with the hepatobiliary system. The presence of white spots and cirrhosis is indicative of vitamin A deficiency. Xanthelasmas, or the yellow-colored plaques on eyelids, can suggest obesity. Hypercholesterolemia or diabetes mellitus. Next is the oral cavity and perioral region. Assess the general health of the oral cavity and look for pathologies that can affect the adequate intake of nutrients. Also look for glossitis, angular stomatitis, and chelosis, which can indicate vitamin B complex deficiency. Bleeding gums and gingivitis are suggestive of vitamin C deficiency. Again, look for pallor. If an eating disorder is suspected, look for vomiting-related oral damage. For example, discoloration of teeth, loss of enamel, cavities, and enlarged salivary glands. A consultation with a dentist may be helpful. Look for loss of buccal pads or sunken facial appearance. This can be associated with various conditions such as eating disorders, marasmus, tuberculosis, or HIV or AIDS. So, assess the general health of the skin. Extremely dry skin can signify vitamin A and or essential fatty acid deficiencies. Petechiae purpura and ecchymosis may be associated with vitamin C and vitamin K deficiencies. Vitamin C deficiency can also present with perifollicular hemorrhage. Poorly healed wounds indicate vitamin C, protein, and or zinc deficiencies. Pigmentation and rashes in sun-exposed areas around the neck and extremities in glove and stocking patterns can be due to niacin deficiency. And the yellow-orange discoloration of the skin can be detected in cases of excessive consumption of carotenoids, pigments found in carrots, pumpkin, tomatoes, and etc. Next is the hair. Various nutrients are required to maintain the health of hair and follicles. Dry hair can be a sign of vitamin A or vitamin E deficiency. Biotin deficiency can make hair brittle. Severe undernutrition, especially protein deficiency, can lead to discolored and easily pluckable hair, eventually resulting in hair loss. Rapid hair loss can be indicative of underlying systemic illnesses. Next is the nails. Assess the general health of the nails and nail beds. Dry and brittle nails can be associated with various nutritional deficiencies such as deficiencies in biotin, zinc, and proteins. Next is the extremities. Examine all extremities carefully. Protein or thiamine deficiency can lead to edema. Vitamin B12, thiamine, vitamin E, and vitamin B6 deficiencies can present with paresthesia and muscle weakness. Loss of vibration and position sensation can also be observed in individuals with vitamin B12 and or vitamin E deficiencies. Next is odors. Certain odors can be suggestive of specific disorders or substance use. Detection of fruity acetone odor in patients with ketoacidosis, musty odor in patients with phenylketonuria, sweet burnt sugary odor in patients with maple syrup disorder, or the smell of alcohol can also be helpful during the examination of patients. Next is the anthropometric measurements. So measure the weight and height of the patient. Patients should be advised to avoid wearing heavy garments or shoes while these measurements are taken. Bed or chair scales may be needed if patients are not ambulatory or cannot stand. In pediatric age groups, these parameters are plotted on growth charts to assess growth and nutritional status. BMI, weight in kilograms divided by height in meters squared, is also calculated using the parameters, and the state of nutrition can be assessed. Factors such as edema and hydration should be considered while making these determinations, as they can affect the weight and BMI values. BMI cannot differentiate between muscle mass and adipose tissue or fat mass. And finally, BMI does not take into account micronutrient deficiencies. Other anthropometric measurements like circumference, arm, abdomen, and thigh measurements, and skin fold, triceps skin fold, subscapular skin fold, and suprailiac skin fold thickness measurements can also help with the evaluation of nutritional status. Skin fold thickness measurements are considered indicators of energy stores, mainly lipid stores. Circumference measurement, namely mid-arm circumference, can be used to derive mid-arm muscle circumference, which is an indicator of protein stores. While these tests can quickly be done at the bedside without additional cost, subjectivity in terms of measurements and the applicability of results across various populations can make these tests less reliable. A complete anthropometric measurement may also involve body composition measurements, which are discussed in diagnostic tests. So next is the diagnostic test. Then this is the component of the nutritional assessment, which is done to validate the results of the clinical presentation. We have laboratory tests. Routine clinical tests can help evaluate the patient's overall status as well as nutritional status. This includes serum electrolytes, blood urea nitrogen or BUN, creatinine, blood glucose levels, lipid profile, liver enzymes, and complete blood count. Serum electrolytes and hydration status may be arranged or deranged in malnourished individuals. BUN and serum creatinine are also predictors of nitrogen balance, along with being indicators of renal function, and lower levels of these can be seen in malnourished patients. Low levels of serum creatinine can be indicative of lower muscle mass. Both BUN and creatinine levels, however, can be affected by hydration levels and kidney function. Elevated blood glucose levels and lipid profile, or triglycerides and cholesterol levels, are indicators of metabolic syndrome. Hyperglycemia can also be a non-specific indicator of the inflammatory response. Next is the low cholesterol levels can be seen in undernourished individuals. Low hemoglobin is suggestive of anemia. Lymphocyte functioning and proliferation are affected in chronic malnutrition and may manifest as decreased lymphocyte count. Undernutrition and protein deficiency in general lead to impaired immune response. Taken together, an impaired, delayed hypersensitivity response, allergic or no reaction can be seen or may be seen in undernourished individuals. For example, malnourished individuals with TB may show an allergic tuberculosis skin test. So, visceral proteins, levels of visceral proteins such as albumin, prealbumin, transferrin, and retinol-binding protein can help evaluate nutritional status. However, none of these tests alone are specific for detecting malnutrition. and their levels can be affected by multiple factors. Next, micronutrient levels. If specific micronutrient deficiencies are suspected, individual micronutrient levels can be measured. For example, levels of B vitamins, the thiamine, riboflavin, niacin, pyridoxine, folic acid, and B12, vitamin A, iron, zinc, selenium, homocysteine, etc. can be measured. More specific tests such as the skilling test for B12 deficiency or iron panel to differentiate between different types of anemia can also be performed based on clinical presentation. Other non-nutrition specific markers can also be used. For example, C-reactive protein or CRP can be used to indicate inflammation.
So now I will be discussing about the medical and surgical management. So first is on the medical management. Number one is treatment of malnutrition at home. So first is the diet planner will advise and discuss the diet to the patient and makes recommendation to improve the nutrient intake of the patient. In most patients with malnutrition, the intake of protein, carbohydrates, water, minerals, and vitamins need to be gradually increased. And also, supplements of vitamins and minerals are often advised. Those with protein energy malnutrition may need to take protein bars or supplements for correction of the deficiency. The body mass index is regularly monitored to check for improvement or responsiveness to dietary interventions. Occupational therapies and a team of physicians of different specialties may be necessary for people with disability who cannot cook or shop for themselves, or those who have mental disorders, dementia, or long-term illnesses. Those who are difficulty in swallowing, chewing, or eating may need to be given very soft or cured food for easy eating. Treatment of malnutrition at the hospital. The team of physicians and healthcare providers who manage malnutrition patients includes a gastroenterologist who specializes in treating digestive conditions, a dietitian, a nutrition nurse, and a psychologist, and also a social worker. Nasogastric tube feeding, PAG feeding, and intravenous infusion or parenteral nutrition be done in the hospital for moderate to severely malnourished patients who are unable to take food via a mouth. And for those who are unable to take food by mouth, some patients are completely unable to take food by mouth. These patients may be treated by feeding with artificial tube that are inserted via the nose into the stomach. This is called the nasogastric tube, and special nutrient preparations in liquid form are given via these tubes. Nasogastric tubes are designed for short-term use and may be used for up to 6 weeks. And in some patients, a tube may be surgically implanted directly into the stomach. It opens outside over the abdomen. This is called a percutaneous endoscopic gastrostomy or PEG tube. Nutrients in the form of liquids may be given via PEG tubes. This is useful patients with esophageal cancers or other pathologies that make feeding via the mouth and esophagus difficult. This lasts for around 2 years and may be replaced thereafter. Treatment for pregnant women. Pregnant women require more calories and nutrients than non-pregnant women as their fetus grows. Iron, folic acid, and other vitamins and minerals need to be supplemented in women who are pregnant with or without malnutrition, as these are often required in higher amounts than normal diet can provide. This requirement, however, does not translate into eating for two, as this may lead to excess calorie intake, leading to maternal obesity, but malnutrition alongside as the vital nutrients may be lacking in diet. And for the treatment of malnutrition in children, during growth years, the requirement of nutrients usually is high and such demands need to be met adequately. Regular visits to the pediatrician for assessment of adequate growth in height and weight is essential. Malnutrition causes more problems in children than any other age groups as they may lead to growth, both physical and mental, retardation and susceptibility to repeated infections. Children with protein energy malnutrition or PEM need to be identified. This includes children with marasmus or kwashiorkor. These children require aggressive therapy. Children with long-term diseases need therapy for malnutrition as the prophylactic measure. This includes additional nutrients, vitamins, and mineral supplements, and etc. This underlying disease also needs to be treated adequately to prevent malnutrition. Children with severe malnutrition need therapy in the hospital. This includes parenteral nutrition and slow introduction of nutrients by the mouth. Once their condition stabilizes, then they can gradually be introduced to a normal diet. These are the prevention of the malnutrition. So first is bread, rice, potatoes, and other starchy foods. This forms the largest portion of the diet and provides calories for energy and carbohydrates that are converted to sugars, which provide energy. Next is milk and dairy foods, vital sources of fats and simple sugars like lactose as well as minerals like calcium. Next is fruit and vegetables, vital sources of vitamins and minerals as well as fiber for better digestion health. Meat, poultry, fish, eggs, and beans, and other non-dairy sources of protein. These form the building blocks of body and help in numerous body and enzyme function. For the surgical management, as many as 2 of every 3 major surgery patients are malnourished preoperatively. Diagnosis rarely made and treated even less frequently. Unfortunately, perioperative malnutrition is perhaps the least often identified surgical risk factor and is among the most treatable to improve outcomes. 2 perioperative nutrition guidelines emphasize preoperative screening for malnutrition risk, using CT scan and ultrasound lean body mass evaluations, preoperative nutrition optimization, immunization, fasting avoidance, high-protein nutritional supplements, and early oral intake have been shown to improve outcomes. 2 perioperative nutrition guidelines emphasize preoperative screening for malnutrition risk using CT scans and ultrasound lean body mass evaluations, preoperative nutrition optimization, immunization, fasting avoidance, high-protein nutritional supplements, and early oral intake have been shown to improve outcomes. Preoperative identification of the malnourished surgical patient is paramount to improving nutrition status during the preoperative period. Screening for a malnutrition prior to elective surgery can identify patients at risk for malnutrition who may benefit from preoperative nutritional intervention. The risk of preoperative malnutrition is often most significant for oncologic and gastrointestinal surgeries, where 2 out of every 3 patients presenting for surgery are malnourished preoperatively. These high-risk surgeries are also often targeted by enhanced recovery programs, allowing for more meaningful optimization to occur. While several screening tools have been validated for use in hospitalized patients, no universally accepted screening tool for preoperative malnutrition risk has been available.
Hello everyone, this is Mika and I will be presenting the nursing intervention and family education of failure to thrive malnutrition. For the nursing intervention, first is to facilitate nutritional consultation. So this is actually the process of providing personalized guidance and recommendations on diet and nutrition to help individuals meet their health and wellness goals. And for example, is to conduct a thorough assessment and provide education. So next is, if hospitalized, provide a primary care of staff to feed the child, ask the parents to do so when present in a non-threatening manner. So this is to ensure a continuity of care and respects parental involvement in a supportive manners. So third is develop individualized teaching plan to instruct parents of child dietary needs, specify type of diet, essential nutrients, serving sizes, and method of preparations. So develop a personalized teaching plan for parents on the child's dietary needs, such as a balanced diet rich in fruits, vegetables, lean proteins, and whole grains. It also needs to explain essential nutrients like vitamins, minerals, and fibers. Provide serving size guidelines and demonstrate healthy meal preparations methods. Fourth, provide a quiet, non-stimulating environment for eating. So this can help to reduce distraction and promote mindful eating. This can also lead to increased enjoyment of meals and improve overall health. Fifth, demonstrate proper feeding technique, including details on how to hold and how long to feed the child. So holding the child in a semi-upright position with their head supported is the appropriate position for the child, and offer small spoonfuls of food and allow them to swallow before offering more. Feed slowly, pausing between bites, and observe cues of hunger or fullness, and stop feeding when the child shows disinterest. So sixth, administer multivitamin supplements as prescribed. So we also need to ensure that the child takes the supplement with food to enhance absorption. Seventh, encourage nutritious, high-calorie, and fortified fluids to increase nutrients density. For infants, use 24 to 30 cal-ounce rather than 20 cal-ounce. For older children, suggest fruit smoothies using whole milk and ice cream. 8. Refeed the malnourished child with caution, monitoring electrolytes, calcium, magnesium, and phosphorus daily or more frequently if abnormal. It can gradually increase nutrients and use small frequent feeding with adequate fluids to ensure hydration. It is also monitor intake and output. 9. Maintain high nutrients diet until weight is appropriate for height, usually age 4 to 9 months. Maintaining a high nutrient diet until weight matches height support healthy growth and development. Adequate nutrition during this critical period ensures optimal physical and cognitive development, setting the foundation for lifelong health and reducing the risk of future health issues. Last but not the least, advise family that some nutritional intervention will be continued until appropriate height for age is reached. Continuing nutritional intervention until reaching appropriate height for age ensures optimal growth and development. Consistent support will promote a healthy future and reduce the risk of long-term health complications. For family education, first is reinforce the need for a quiet, non-threatening, nurturing environment. This is important for a child's overall well-being and development. It can help reduce stress and anxiety, allowing the child to focus on feeding and promoting a positive mealtime experience. This environment can also help create a sense of safety and comfort, which is crucial for children with feeding issues. Second is encourage the parents to be consistent with feedings. Although forced feeding is avoided, strict adherence to appropriate feedings is essential for growth. Consistency with feedings is key for children with feeding difficulties. It helps establish a routine and promotes a sense of predictability, which can be reassuring for the child. Missing or skipping feedings can lead to nutritional deficiencies and hinder the child's progress. So by being consistent with feedings, parents can help the child develop healthy eating habits and improve their overall well-being. Third, advise the parents to introduce new food slowly and follow the child's rhythm of feeding. So introducing new food slowly and following the child's rhythm of feeding allows them to explore and become familiar with different tastes and textures at their own pace. This approach can help prevent mealtime stress and resistance, making it more likely for the child to accept new food in the long run. Fourth, review the importance of providing a routine, rest schedule, and environment that is conducive to sleep. This is important for a child's overall health and development. Consistent sleep patterns promote optimal brain function, emotional well-being, and physical growth. Creating a calming sleep environment can help the child relax and fall asleep easier, supporting better quality sleep. Fifth, review development, stressing need for visual, auditory, and tactile stimulation, and age-appropriate toys for continued development. So this is the age-appropriate toys that encourage exploration and learning. Providing varied sensory experiences can support the child's cognitive and motor skills development. So last but not the least is reinforce the need for follow-up care, well-child visits, and immunization. Follow-up care, well-child visit, and immunizations are essential to monitor growth, development, and overall health. Regular checkups can help identify any issues early and ensure the child is receiving necessary vaccinations to prevent serious illness and protect public health.